Garrett Schmidt, and I am the CEO and Managing Editor of VBC Exhibit Hall. And I'd like to welcome you all to today's live webinar hosted by WellSky. And this one's called Emergency Department Transitions, Improved Outcomes for Patients, Payers, and Providers. We've got a lot of material to cover today, so we'll get right to it here shortly, but a couple items of note. Before we get started, this is a listen-only format that you've joined today, so you don't need to worry about turning off your camera or your microphone. That's been done for you. So we just want you to enjoy and listen and hang out with us today, but we are going to have some audience questions that we're going to ask, so feel free to participate in that. We'd love to hear your feedback and some of your thoughts. Also, we're going to have a time for some Q&A throughout the presentation. So if you have a question at any point for either of our speakers today, go ahead and use your attendee module, and there's a space for questions specifically. So I'm going to have you drop your question there, and we're going to get to as many as we can today. If for some reason we're not able to get to yours, don't worry, someone will make sure to reach out via email to make sure that your question gets answered, because again, we have a big audience and we have a lot of material to cover. So finally, the session today is being recorded, and so what's going to happen is when we conclude, you will receive an email, maybe about an hour or so after we conclude, that will have a link to the recording as well as to the slides. And there's going to be a lot of material on the slides, so you're definitely going to want to download those later on. So without further ado, I wanted to briefly introduce our speakers today, and then they will be our guides for the discussion. With us, we have Ms. Bridget McGrath, and she is the Senior VP and General Manager of Clinical Services with WellSky. And she is an RN by trade and a previous manager of an ED. And then we have Dr. Jamie Cheng. He's an MBA and FACEP, and he is the Chief Medical Officer with WellSky. And he is a board-certified emergency medicine physician. So the speakers that will be speaking to you today about this topic are well-versed in this material and in this information and have a great background. So without further ado, Jamie, I think you're going to kick us off. So I'm going to turn it over to you at this time. So welcome to you both.
Great. Thanks so much, Garrett. And I appreciate the opportunity to share this topic with you all today. The way that we'll structure our time is I'll start off with a high-level overview of who WellSky is, kind of what WellSky does. And then we'll dive into kind of by stakeholder, how we're thinking about the emergency department and specifically transitions from the emergency department and where there can be value creation across the spectrum of providers, which I'll cover. And when I talk about providers, I'm primarily thinking about emergency department teams in addition to hospitals and health systems. I'll then turn it over to my colleague, Bridget, who will talk us through how we're thinking about the emergency department creating value for payers, whether that be a health plan, a risk-bearing medical group, or other risk-bearing entity, and also, most importantly, for patients. We'll wrap up then. And again, we encourage you to submit questions, and we'll take time to go through a couple of poll questions during the course of the presentation as well. So to start out in this first section, I'm going to tell you a little bit about WellSky and kind of the role that I get to play there as its Chief Medical Officer. So WellSky I view as really leading the movement for a really tech-enabled, intelligent, and coordinated care. In this new era that we're operating in with a lot of AI kind of benefits of technology and aggregating lots of clinical information, I really think about WellSky as, yes, a health technology company, but also with a growing clinical operations arm to unlock services and deliver solutions to really drive the right outcomes that we seek across healthcare. And so we think about WellSky kind of comprising software, analytics, and clinical operations services to enable multiple stakeholders in the healthcare ecosystem, again, whether it be providers or payers, to really focus on delivering better outcomes at lower cost. And we can go to the next slide then to give you a sense of the footprint or the install base for WellSky. WellSky represents the most complete care coordination network available today across the United States. So this is not kind of one of the startup health tech companies, but this is a scaled install base across acute, post-acute, and community-based organizations, where the WellSky network is connected to 2,500 different hospitals, ACOs, and physician practices. Beyond the kind of acute side and the ACOs and physician practices, we're actually connected to over 130,000 post-acute providers comprising multiple levels of care, whether that be SNF, home health, private duty in the home. And the WellSky technology is being utilized to facilitate about 17 million discharges per year coming out of the hospital space. And we're primarily doing that by facilitating referrals being used by hospital case managers and discharge planners. There's about 54 million referrals per year that are going through the WellSky technology as hospital-based employees that use the technology embedded within their EMR to find post-acute placement. We also, through our direct connections across the healthcare ecosystem, have about 12 million event notifications per day. So different to your HIEs and other aggregators, WellSky actually has direct connections into these hospitals that allow us to have more timely and more informative event notifications for patients that do present and register for ED care. Go to the next slide then. So we'll dive into the topic today, which is just the challenges that face emergency departments. And I've spent about the last 20 years of my life working in emergency departments, primarily in California. And I think that we've seen, especially post-pandemic, the magnitude of emergency department challenges just growing exponentially. And I think it's a function of higher acuity, more complex patients accessing the ED in combination with some level of burnout from the ED workforce that I'll say, like a lot of my colleagues dropped out of clinical practice during the pandemic, and from a physician, nursing, case manager, social work standpoint, it's just a very challenging environment to be in with a lot of crowding that's well documented here, sometimes a difficult patient population, oftentimes more patients that we can handle, right? We've got busy waiting rooms, we might have ambulances out the door, and access to inpatient capacity can be challenging, which results in a lot of boarding and overcrowding. I recall sometimes going in the ED on a Monday morning, and half of the department would be boarding patients still waiting to go upstairs. And so we would be very limited in our capacity in the ED to take in new patients. And oftentimes that meant trying to take care of patients in the waiting rooms, right? And so I think that emergency department crowding and boarding has been a crisis for a long time. And I know there's been many efforts to try and drive throughput here. And I think part of my role at WellSky is to think about how to use the technology to connect the different parts of the healthcare system better to alleviate some of the strain at the front door of the hospital. And so if we go to the next slide then, we really think about these challenges in the ED impacting multiple different stakeholders. Again, from a patient experience standpoint to provider challenges and payers under increasing pressure at the front door of the hospital. And so a couple of kind of root causes here. I think there's limited continuity of care in the ED. When patients turn up to the ED, oftentimes the ED is flying blind. We don't have much context about the patient we're seeing. We really focus on what's the life or limb threatening issue, and then hoping that a PCP or someone else can pick up the patient. But there's limited continuity here and transfer of information to ED teams. ED care can be costly, right? It's costly to patients, it's costly to payers, but it's oftentimes the only access point a patient may have to getting in to see a physician that day. But we recognize that it's not the right place typically to deliver chronic disease management and ongoing care. Freddie talked about a little bit the crisis of boarding and overcrowding, and that the ED is seeing more high acuity and complex patients. We think that kind of part of the reason for the increased ED utilization is also ties into low member engagement. When patients are not engaging well with the outpatient systems of care that have been set up for them, where do they often end up? They turn up registering for care in the ED. And we know that that's fragmented, siloed care and not really part of the broader healthcare ecosystem that is really needed to deliver better patient outcomes. And a result of this, we really see a lot of challenges in quality scores, both on the hospital side, where the hospital core measures with regards to length of stay, left without being seen rates are really strained by the crowding and boarding. And on the payer side, especially those of you working with Medicare Advantage patients, some of the HEDIS measures like the FMC measure, so follow-up after ED care within 7 days for patients with multiple chronic conditions. Because ED care is unscheduled, there's no authorization process, it's often challenging to get timely visibility into an ED visit for an at-risk patient to ensure that it's appropriate follow-up there. And so kind of that's how we see the world with regards to some of the challenges in the ED, but we'd love to hear from you some of the challenges that you all see both with low value ED utilization and also when patients get to the ED, some of the reasons for why these patients maybe get unnecessarily hospitalized. So let's go to the first poll question. If we can go to the next page here, Mila. And Garrett, I might ask you to help tee up the poll questions for our audience here.
All right, you got it. So you should all see this on your screen right now. This is, by the way, we're going to have several of these throughout the presentation to play along at home. And the question is, what is the primary driver of avoidable emergency department utilization in your organization? And these are anonymous, by the way, so these are just for fun. So feel free to participate. In the results are rolling in. Is it limited access to timely primary care? Is it behavioral health or social needs? Is it lack of patient education, health literacy issues? How about post-acute or care coordination gaps? Or not sure, the data is not clear yet. And you may be saying, well, it's a little bit of all these things. But if you had to pick, what would it be? So it looks like most of the results have come in at this point. I'm going to give it maybe another 5 long seconds, and then we'll close it down. 5, 4, 3, 2. Oh, they're still coming in. And 1, and then we'll show the results here. Okay. Jamie, Bridget, are you able to see these on your screen?
Yeah, we can see them. And I think the 3 rising to the top here, but it's a pretty close tie across the board, actually. But the highest one was limited access to timely primary care. And so this idea that if I can't get in to see my PCP, let me just go to the ED and see if they can resolve the issue. Close second here was lack of patient education or health literacy. Like, what is the right types of complaint or issue that is appropriate to go to the ED for versus using some other type of triage mechanism, whether it be a call us first program or a telemedicine that kind of patients just voting with their feet to go to the ED. I think 3 and 4 here were behavioral health or social needs, which certainly we do see a lot of behavioral health in the ED, and they often end up with a lot of boarding, and the ED is challenged with finding appropriate placement for these patients to stop the cycle or the kind of revolving door of just going back to the ED for behavioral crises. And then post-acute care coordination gaps. So I read into that as kind of failures of follow-up. If it's a patient that maybe had a sentinel event, whether it be an admission or a prior ED visit, but the issue hasn't been resolved, so they kind of miss their care coordination gap and they just end back up in the ED. So please feel free to put in the questions if there's anything else I might have missed, but that's how I'm interpreting this. Bridget, is there anything else that you would comment in with these results?
No, I think I think it's actually nice to see that a lot of people have insights into what's driving it. Actually, there's not very many who think that they're not clear on the data, so clearly have some line of sight. So these are definitely now challenges we can start undertaking if we understand the primary drivers. So it's great to see the audience has visibility into that.
Thanks, Bridget. Garrett, let's go to the next question then about once patients do end up in the ED, what happens next?
Next question is launching now. Okay, what is the primary driver of avoidable hospitalizations being admitted from the ED? And same deal as before, choose one that best applies here. Is it ED provider decision making, risk aversion, limited case management, and discharge planning support in the ED? Is it lack of appropriate outpatient options for post-ED follow-up, difficulty accessing post-ED follow-up care, or there's no time for the ED team to consider alternative options? So take a second here and figure what makes the most sense in your organization.
So if we think about the prior question about why a patient's showing up to the ED, this question is more focused on when the patient is in the ED, why do we see so many ED admissions or ED placement in OBS that potentially could have been avoided?
Yeah, and well, looks like the results are still coming in, so we'll give it maybe another 10-15 seconds here. And by the way, Jamie, I may have you read out the percentage results scores for those who might be calling in who can't see it visually. Sure. We show the results here. Okay, I'm going to give it another about 5 seconds and close it down. 5, 4, 3, 2 and 1. We always have one coming right there at the end. So, all right, I am sharing the results for you.
Great. So looking at these results, again, I'll go from most kind of frequently voted on to least, but it looks like 34% of the votes came in that there's a lack of appropriate outpatient options for post-ED follow-up. And I think that's totally fair that often in the ED, you don't have good visibility to, first of all, who is this patient's outpatient care team and what can they offer for the patient. The options are typically here: do I admit the patient and let the hospitalist and the inpatient case management team take care of it? Or do I discharge the patient and put in the instructions, follow up with your PCP and kind of wish them the best and good luck in navigating healthcare once they leave and hope they make it to a follow-up? So I think that's certainly a driver here. Just thinking about the ED's decision making, I'm not confident that there are outpatient options available, but let me just go ahead and admit them and make it someone else's issue to try and figure that out. The second one here was 20% of the vote was ED provided decision making, kind of risk aversion and burnout. And I'd say that's certainly true. And I kind of raised my hand as being guilty of this myself, right? When I'm getting close to an end of a shift and I'm trying to get home for dinner with the kids, that oftentimes the easiest option here is again just to admit them. And it's just a lot more work to try and coordinate the follow-up care. And I know how kind of wasteful that is and how challenging that is from a payer standpoint with regards to managing medical expense. But the reality of the situation is you've got a relatively burnt out workforce in the ED that's trying to solve for themselves. And oftentimes it's their decision making that leads to some of these what we call unnecessary admissions or hospitalizations. I think I'm seeing third on the list here. It's a close between the remaining three. 18% of the vote was that there's limited case management, discharge planning support in the ED. I think that having been a hospital administrator for a number of years, we will always make sure to staff the inpatient case management teams first to manage inpatient length of stay and make sure there's good throughput on the inpatient units. And the ED, sometimes they're lucky to get a social worker. I think it's a luxury sometimes to actually get a case manager dedicated to the ED, maybe Monday through Friday during business hours. But yes, there is less support in general, I'd say, for care coordination for patients leaving the ED. And then finally, the kind of difficulty accessing post-ED follow-up care is kind of 16% of the vote, and then finally no time for the ED team to consider alternative options at 12%. I think these are all somewhat linked and correlated, but certainly this resonates with me in terms of my time in the ED as to why there's so many hospitalizations from the ED that could potentially have been avoided. Bridget, any other perspective you have from these results we see from the group?
No, I think, it doesn't surprise me that lack of appropriate outpatient options is the first and the highest, because it's sometimes not even the lack of them, it's even the knowledge of them, with so many multiple payers coming, into the ED, so many patients coming, what is available to them with the different benefit structures, or even what's available in the community is, with community-based organizations. So that one really doesn't surprise me. It's what I think I would expect it to see for this one.
Thanks, Bridget. Okay, well, we can get back to the presentation. So this is that was the intro to WellSky and maybe some of the challenges facing the ED. We're going to spend the rest of our time again talking specifically about what WellSky is doing to support transitions from the ED, and I'll talk about specifically for providers. Then I'll hand over to Bridget to discuss a little bit more around what we're doing for payers and what we're doing to create value for patients as well. And so this slide is really to try and capture on a page how WellSky is seeking to support transitions more efficiently and effectively from the ED. And so the top half of this page really just speaks to, I think this has to be value add for the actual frontline ED team to start. And so WellSky is really leaning into sharing clinically relevant information with the ED team. I think we discussed earlier how broad the WellSky network is across hospitals across the US and the post-acute space. And with some new AI capabilities, how do we generate clinically relevant information for the ED team so they have more context about the patient that they're seeing, what kind of the recent workups have been like, what's this patient's level of engagement with the outpatient team, but just provide that ED team with some support that here's maybe some information that you can't already access through your own hospital EMR. And whether that be a discharge summary, an H&P, an assessment and plan from another provider, we're just trying to equip that ED team with more information. In addition to providing the ED team with more clinically relevant information, we are also then supporting the EDs by facilitating transitions to outpatient services in the community, whether that be for PCP specialist follow-ups, some type of home-based care, if that patient needs some type of DME or home infusion, or even in some scenarios, post-acute facility placement. If there are some patients that would be more appropriate for something like an ED to SNF direct transfer, then those are the types of options we're trying to provide to the ED. So it's not just a black and white admit or discharge, but more of a supported discharge pathway where we can get patients plugged into better follow-up ED care. And as we discuss these programs with our hospital clients, we really see the value here for hospitals across several key areas, and that's throughput, experience, and inpatient mix. So starting with throughput, the idea here is that if we can increase or enhance the visibility that the ED has to reduce kind of duplicative diagnostic workups, that can help with throughput. So if you know that this patient, for example, just had a CT angio for a pulmonary embolus at another ED down the road last month, then that may change kind of how much diagnostic workup you need to do in the ED for that visit. Or this patient just recently had a stress test that was negative and benign, or recently had a cardiac cath, and it just changes like how much workup is needed in the ED for that particular patient's complaint. And I think the other part of throughput here, again, as we think about boarding in the ED, is we're really striving at WellSky to proactively coordinate with the outpatient care teams that are going to be responsible for taking care of this patient once they leave the ED, to see even things like boarding rounds, like every patient boarding to go upstairs. Are there other ways we can connect that patient with the outpatient team and see if that would be a reasonable disposition as opposed to kind of sitting in the hallway of the ED. From an experience standpoint, the goal here, again, is to try and create more connections across the healthcare system to link patient care plans across settings. And we believe this creates a more unified approach to things like managing SDOH. If we think about kind of pain plans for our sickle cell patients and other chronic disease management and kind of plans of care, how do we make sure there's broader visibility for that across the patient's care team, including the ED team, as they're taking care of the patient? And finally, warm handoffs here from an experience standpoint. The ED is already very familiar. If they admit a patient, they're going to give a warm handoff to the inpatient team. The ED physician is going to call the hospitalist, nursing is going to give a handoff. But if that patient's discharged from the ED, there isn't really a mechanism right now to create a warm handoff between what's been done in that ED stay and that patient's PCP, or the next care team that's going to take care of that patient. So really trying to facilitate through the technology the ability to do a warm handoff between the ED and the next site of care if they're going to discharge the patient. Finally, for our hospital and health system partners, we really think about kind of one of the pain points we hear from them all the time is struggling with inpatient mix. A lot of social admits coming through the ED, a lot of underserved patients that aren't plugged into the right community resources, ending up in the ED, and then for the reasons we just discussed, ending up in an inpatient bed where the inpatient teams aren't well equipped to deal with these patients either. And so as we think about supporting mix, we think about supporting ED transitions as helping to reduce some of these social admits that just maybe need observation and placement, free up the capacity for the higher acuity patients, and really doing our best to connect the underserved with the right resources they need for ongoing care, rather than kind of just quote unquote dumping them in the hospital and not having good resources available to them. We really want to find and connect these patients to the right levels of expertise to get them the care that they need. If we go to the next page then, this is another way we're thinking about what this looks like for the ED team. And so this is a prototype that's in development, but it's a vision here, given WellSky's integration with hospital EMRs to support things like discharge planning. We have kind of envisioned here an ED landing page that would be accessible to the ED team either via the ED trackboard, or when they click into a patient chart, a link here to this ED landing page. And the key components here would be that we are able to draw upon all the clinical information and data we have on these patients, again, across multiple different hospitals, across multiple levels of care, to provide the ED team with an AI-generated clinical summary specific to whether it's an ED physician or an ED nurse, ED case manager, kind of tailored to the information they need to see, with an ability for them to then query the WellSky network of data to get additional information, actually even also have some WellSky RNs available remotely to help coordinate outpatient care via secure chat. So both surfacing what types of post-ED follow-up care is available, and then actually having a mechanism if they don't have the ED case manager live and in-person boots on the ground with them, but a pathway to access the population health resources and the care teams to actually coordinate that follow-up care. And so with that, we'll move to one more poll here, and then I'll hand it over to my colleague Bridget to talk about kind of what we're doing with payers and how we're creating value for patients. So Garrett, over to you for this third poll question.
All right. You all should see this on your screen. If you're joining us lately, we are having several of these that are anonymous and they're just for fun. So feel free to participate. And this question is, which care coordination resource is most available to your organization today? So again, if you had to choose one that was most available, is it care managers embedded in your primary care? Is it community paramedicine or mobile response teams? The health plan case management support? Hospital-based transition or follow-up programs? Or we have very limited resources today. So if you had to, again, choose one that kind of was most available, what would you choose? And we're going to share the results here shortly. I'm going to give it maybe another 10 seconds or so for folks to respond. And then we'll see the results. Okay. Looks like most people have responded to this point, so I'm going to close it down in 5, 4, 3, 2, and 1. All right. Jamie.
Yeah, let's talk through these results. And again, acknowledging here that most of the audience are from value-based care entities. I see a lot of population health kind of surfacing here. So the highest ranked one, or the most frequently voted one, was at 42%, was care managers embedded in primary care. Understanding a lot of the kind of the risk-based entities are focused on primary care practices, which is the right place to start for chronic disease management and preventative care. Makes sense to have care managers embedded in primary care. The second most frequently kind of voted one was 30% at hospital-based transition or follow-up programs. So as we think about how to pick up these patients once they leave the hospital and support these patients with their transitions of care, that also makes a lot of sense. The remaining 3 were more limited. So at 14% was limited resources today, at 12% was health plan case management support, and the final one was community paramedicine mobile response team, which only there was 1 vote for. So that's more of a scarce resource. But certainly, I think what stands out to me is a lot of focus right now on primary care-based kind of care management, and then transitions of care, kind of follow-up, where I'm guessing it's mostly post-inpatient stay type of transition of care for post-discharge visits is coming out as the most available care coordination resource. Bridget, anything else you see here?
No, I think you summarized it well, especially with the audience that we have today, as you said, participating, that we see more that care managers. Often, when you talk to a different audience, or potentially just hospitals or payers, it's a very different response. So I think that a lot of this audience is on the value-based care journey, which then does lead to some of these answers that we've seen in, the registrations. But I think the limited resources we run often in that, and even where there are care managers embedded or there's health plan support, it's often that coordinating and knowing what's available in the community for these patients, as well as then completing and closing that loop, because there's so many other things for them to get done while they're in the emergency room prioritizing. So it's also how they spend their time when they are available in the ED or care management in the primary care groups. So yeah, very interesting to see the answers of these polls come through. So I think with that, Garrett, we're going to move on over the next couple of minutes. We'll really go through the value that how we're working with payers today, as in Wales, how we're working with payers today and the value for payers, and then we'll go on to really ultimately what we're here for is to serve patients better. So looking at the payers, we spoke about this common theme. Jamie spoke about, getting engaged in the ED, but then how do we partner and bring the payers together with the EDs? And that could even be your fee-for-service patients, your Medicaid payers, depending on what is your mix that are in your ED, really partnering with your payers to do these. And we have some programs live today, and this is an example of how we partner with payers in different markets. So notification, knowing that that patient is in the emergency real time, that have landed up in the ED, that we know that that patient's there right at triage, not waiting until that patient has already gone through, started treatment, now getting admitted, and then only having visibility. Because at that point, that visibility and that impact point, you can often miss that if you don't have that real-time notification. But just as important is that notification, and along with the information that comes with that notification. So it's great to know that Mrs. Jones has arrived in the ED, but why is Mrs. Jones there? What information is available about Mrs. Jones, whether that is she was recently discharged from a skilled facility. Mrs. Jones has, had, Jamie spoke about it, already had multiple tests and workup done. What were the results of those? And is that a reason that Mrs. Jones is in the ED? Really on her chief complaint today, and then understanding any previous ED, whether that's in your ED or in one ED or multiple. With the WellSky technology, we can see across the healthcare ecosystem to absolutely visualize, as Jamie showed in the previous slide, some insights into Mrs. Jones and extract that really relevant information. But then surfacing the options available for Mrs. Jones, if deemed appropriate, for the ED team to consider. That raising the visibility of maybe Mrs. Jones is part of an LTSS population and has 8 hours of personal care at home every day. Could Mrs. Jones go home? Or is Mrs. Jones affiliated with different PCP groups that have wraparound services, that have in-home high-risk population health management? But knowing that about the patient as they arrive in the ED is critically important. And when we partner with our payer clients, we're able to add that attribution as well as these service offerings for the ED team to consider and select as potential discharges. We really participate with the ED team, but the ED team is the one that determines the appropriate follow-up care or whether the patient gets admitted or not. We're surfacing insights about the patient and potential options for them to consider, and then coordinating that care. We heard earlier in one of the polls that we don't even know about it, but then how do we coordinate and make sure that Mrs. Jones is going to have her follow-up visits, that she's going to be able to see her PCP, really while Mrs. Jones is in the ED, and if appropriate, coordinate that follow-up care, get that PCP appointment scheduled so that Mrs. Jones has it in the home. Does she need DME? Is there some home-based care she needs, or potentially partnering with your post-acute care facilities for direct admission directly into skilled facility, and then confirming that transition plan, communicating it back with the ED team. And then Jamie spoke about that FMC and HEDIS gap close, that we can confirm those and do those as well. So we have implemented this with payers in the markets today, and we've seen some great early outcomes. Jamie, I don't know if you want to speak a little bit about some of the outcomes that we've seen on these programs that we are now live with.
Yeah, happy to, Bridget. And so whether it be a health plan or a risk-bearing medical group, I think some of the outputs or outcomes we've seen is that the likelihood of hospitalization for certain diagnostic areas has significantly decreased just with visibility into what is available for these patients when they go home. So if you think about it in a very specific example, let's say if a payer has a CHF specific program, then I think from the ED's perspective, if they can get enough LASIKs on board, get that patient breathing comfortably, and make sure that there's kind of a CHF specific program available to pick up this patient, that may avoid kind of a short stay hospitalization. We've also seen much higher rates of PCP follow-up for patients leaving the ED, just because we're taking advantage of that patient being a captive audience in the ED, kind of in a healthcare interaction at this point in time. And so the extent to which we can confirm that you'll follow up with your PCP at this date and time, it just helps close the communication or patient engagement gap, where I understand a lot of kind of post-ED or post-hospital kind of efforts to engage patients can be challenging. Just getting the patient to respond or pick up the phone. But if we're able to interact kind of in the moment while that patient's in front of the ED team, we've seen the level of engagement go way up for them to kind of re-engage with the outpatient care team once they leave.
Thanks, Jamie. If we go into the next slide, we'll talk about some of the value that ultimately that we are here for the patients. And I often use this, is I think about all the information we have available about ourselves today or about our parents. And that if I landed up in an ED or a loved one did, I would want that ED to know as much about me as possible, that they can make best decisions based on everything that is available for me. And if you think about it, it's crazy to think about interoperability we have on everything almost but healthcare. With interoperability, you can order a pizza and go back 6 months and know what you ordered, what toppings you did, how quickly it got to you, and whether you want to do that same order again, and you can provide that. You know, Amazon, think of all the tracking we can do, but somehow in healthcare, this is missed. And I think that really negatively impacts a patient. If we think about loved ones that arrive into the ED and go to the ED, especially the elderly, and something has happened to them, they've landed in the ED, and providing as much information for that ED team about that patient or your loved one you'd want them to have, which really then does improve the experience and the outcomes for patients landing in the ED. So really going through, we did speak about that notification, surfacing of the information, the insights and finalizing disposition, the care planning, but then ultimately, you know, what does this mean for if it's ourselves or our loved ones in the ED? Is Jamie spoke about the value for, you know, the providers, for the hospitals, but then for the patients to achieve these outcomes, we really see the improved throughputs, the reduced ED wait times, the quicker coordinated care to be able to take care of the patient, which then leads to fewer patients leaving not treated, but then also accessing to ongoing care management and disease management programs, addressing SDOH needs, so that potentially the ED does not become that first go-to. You know, on that first poll question, we asked about what do we see in, you know, avoidable or people showing up in the ED. A lot of it was about health literacy, about not being able to get into the PCP. So really addressing those challenges at the ED prevents these ongoing reoccurring ED visits that may not always be appropriate. The FMC, you know, HEDIS measures is another one really important, that it's for those chronic care patients that are discharging, engaging with them in those 7 days. Yes, it's a really important measure, but it really is important because they are chronic disease management patients that we need to ensure that they've had their follow-up care, that they have all the med reconciliation done at home, that you're able to address any barriers, and then hopefully end up coming with better outcomes. We haven't had many questions today. We've had one or two, but we'd love to hear from the audience if you have any questions that we could answer before we go to, I believe, our final poll. Actually, I'm going to round out just really highlighting if you want to go to the next slide, just, you know, the takeaway of aligning the value for patients, providers, and payers, which the ED provides us with a unique position and situation to do this. Patients are showing up there for at a vulnerable time. For them they're addressing a need, and that's a time to get them engaged with various programs that they could be enrolled in, that they may be eligible for, that they don't know about, address SDOH needs, or get them set up with their PCPs. So focusing on those improved outcomes leads to much higher satisfaction. Jamie hit on the importance for the providers, that throughput and decreasing return ED visits. And then for our payers, we've seen a decrease in appropriate short stay hospitalizations, and then the improvement in the STARS through the HEDIS measures. So just summarizing that this really it's one of these really unique situations that it is alignment of value for the patients, providers, and payers across the continuum. So we can go to the next slide and the last poll, and then happy to answer any questions. Garrett, I'll hand back to you.
All right, for our final polling question, you should see this up on your screen now. It's how would you describe your organization's readiness to implement or expand ED strategies in the next 12 months? Is it we are ready and actively implementing now? We have a plan, but need resources to execute. We're still exploring what models make sense, or we're not currently prioritizing ED programs. So what is the best answer for your organization? And by the way, as we're waiting for those results to come in, if you have a question, we're going to be taking some audience questions here shortly. Go ahead and submit that now using your control module there. There's a specific place for questions. We're going to get to as many as we can. We have a big audience today, but go ahead and ask that. But if we don't get to your question, someone will reach out to answer your question via email. So, all right, I think most of the results have come in for this last final polling question. So I'm going to go ahead and close it down in 5, 4, 3, 2, and 1. All right, and you should be seeing the results on your screen.
Thanks, Garrett. Thinking about describing your own organization's readiness over the next 12 months to address, as Jamie spoke about this, really we're seeing this a lot more in the headlines. It's now much more visible, solving this ED crisis that we have at the moment. It looks like first 42% are ready and actively implementing. Love to hear that over the next 12 months. Again, I think, it speaks a lot to the audience, and really nice to see the attention being given to that. Very close second with 32% is exploring what models make sense. And, this is understandable with, what's in the healthcare and also where you're located, what mix makes up your ED, who you're seeing as your high ED utilizers that you're looking to solve for. Really understanding that then drives the model as well, and how you can participate in different programs. And then the last two, quite close, 16% have a plan but need resources to execute. I think in this resource-constrained environment we're all in with, margin pressures and workforce shortages, that makes sense as well with what we're seeing, not just in the ED, but across the healthcare system. And then, not currently prioritizing the ED programs. This may be something that you either have under control or it's not a priority at the moment, and it is something that, looking to get to in post 12 months, because we know how quickly that comes. Jamie, anything you wanted to add to what our audience has shared with us?
No, I think you captured it well, and I'm glad that there's a certain level of attention here. And I think some of the questions that we've received may speak to some of this. So, Garrett, I might transition us to address a couple of these questions live that I think may be kind of generalizable for this audience. And if you have questions that we don't get to today, we're happy to follow up by email for things that may be more specific to your particular organization. But the first question I wanted to get to was this question about where would we see the impact of this type of program kind of in your utilization metrics. And I think that there's two areas that I would focus on to the extent you're tracking this. And the first is admits per thousand, and the second is really your ED per K, your ED visits per thousand. And so in this program, we're actually supporting some underserved populations, kind of dual eligible patients, where the ED per K or ED per thousand rates are very high and the admits per thousand rates are very high. And I think a way to frame thinking about the impact here is that if we can think about the ED utilization per thousand less as let's say a bad thing, like it does represent maybe a failure of some of the outpatient systems to keep the patient out of the hospital. But if we can transition the thinking of let's avoid the ED at all costs to if the patient does go to the ED, how can we best engage with them there? Use that as an opportunity for the patients now seeking something from the healthcare system. How can we support them at that moment in time? I'd say the primary result we've seen has been a reduction in your admits per thousand and your ops per thousand. So there is some benefit to your ED per thousand rates if we're able to break a cycle of repeat ED utilization, but the majority of the kind of short-term impact is reducing the number of hospitalizations. So what I'd really consider the short stay admissions or the very short stay observations where the patient's being placed in observation just for placement purposes. So please feel free to put in the chat if you have other questions on the impact metrics, but that's how I'd rank them, is kind of most impact on admits per thousand, followed by ops per thousand, with some benefit on the ED utilization per thousand rates. I think a related question here was around kind of, do you have data to prove what you are seeing? I'd say the answer here is yes. I'm happy to dive into this in more detail, maybe through a follow-up discussion, where there's been a kind of a cohort-controlled study between patients with similar chronic disease burden presenting to similar EDs with similar complaints, and really just looking at the only difference being whether or not we were able to support that ED with additional information and surface what follow-up options are available. And in those scenarios, yes, we did see the kind of the odds ratio of a low-value hospitalization being markedly significantly reduced. And then one more question I'll just put out there for the group that we received was, where does all the information come from? Well, I'd say that WellSky has good visibility across hospitals, post-acutes like SNFs, home health, and even private duty homes. So for those of you that are most familiar with WellSky's technology products to support case management discharge planning from the hospitals, either through like the CuraSpan or CarePort products, I think it's important to understand that WellSky is a much bigger organization that actually has post-acute EMRs. So we have a home health EMR, we've got an EMR used for private duty, kind of non-skilled home care, and we've got direct connections with a lot of the SNFs, so whether it be matrix care, point-click care, and so that's where we're really aggregating the information from. So beyond kind of the referral management products that many of the hospital systems are familiar with, WellSky has just got this nationwide footprint across multiple levels of care that allows us to surface the most clinically relevant information to a treating provider, ensuring that that provider has established a relationship with that patient as the treating provider. How do we surface the most relevant information to that provider at that moment in time? So those were the quick ones that I wanted to enter live that I thought could be more broadly applicable. Bridget, with regard to those questions, are there any other comments, perspectives you have on that?
I think the other one, Jamie, to the first question that we got about, the impact we've seen, and as you spoke about the admits per K, I think it also depends on the lens you're looking at. But if you are participating in any value-based care or risk-bearing arrangements, we've been able to take attributed but unengaged members, and at that point in the ED, get them engaged. So even though they may be attributed or part of certain cohort of members, whether that's a chronic kidney disease management program or high risk program, in-home PCP group, we're able to at that point make sure they become engaged, utilizing that time in the ED as well. Even though they may be attributed, they may not have been engaged to this point.
Yeah, that's a good point, Bridget. Again, speaking to this idea of not thinking about the patient's gone to the ED, kind of we've lost the battle, but like how do we think about working together with that healthcare team to get these patients engaged and plugged back in?
Exactly.
Okay, well, Garrett, I might hand it back to you for the last few minutes here. And if we didn't get to your specific question, I know there was some specific to like the payers you're working with. I think we can get to that via follow-up that we can take offline.
All right, sure. Well, thank you, Jamie. Thank you, Bridget, for a fantastic presentation. Obviously, there's a lot here. There's a lot to think about and a lot of different considerations, especially in this current climate that we're in. So I really appreciate your perspectives. And we have, as you all know, those of you who have joined us for webinars before, we will make these slides available. So what's going to happen is you will receive an email when we conclude here very soon that will have a link to this recording, but also to the slides that you can download. So we hope that you do and that you will review at your own leisure the recording and share it with colleagues and friends, and hope that you do that. What you're seeing on your screen now is a virtual exhibit booth at bbcexhibithall.com for WellSky. And this is where you can really dive deeply into what they're doing, to read up on them, and there's some great resources that they have available. This is free to access, and I hope that you can explore that a little bit. There's a direct link in the slides to this booth, but you can also go to bbcexhibithall.com and find it there. Also, at that same website, BBC Exhibit Hall, is where we're going to be archiving this webinar and all the webinars that we've done for WellSky through the years, as well as others, and a lot of different resources there in our archive library. So check it out. Hope that you do. Finally, if you would like to get a hold of the WellSky team, you can do so here. This email, the info@wellsky.com, and if you or if you would like to contact Bridget and Jamie, reach out here, or I'm happy to facilitate an introduction as well if you would like to reach out to me directly, and if that's easier. But I wanted to again thank you, Bridget, thank you, Dr. Chang, for a fantastic presentation today. I hope you all have a wonderful rest of your day, and we'll see you on the next one. So until then, have a good one. Bye-bye.